All right, hey guys, here's part two because I got rudely interrupted last time. But anyway, so hopefully you were able to go through your packet while you had that pause and take a look at your EKG packet and go through and can determine all the heart axis inside your packet based on the size of the QRSs and then figuring out, smallest versus largest and all that stuff. So if you have any questions about that, I know it can be a little tricky to understand. Send me a message, okay? Or come to class on Monday for the virtual class. I will be on Zoom from 4:30 to 5:30 on this coming Monday. That would be let's see, that would be the 30th. So on the 30th, I would be there um, from 4:30 to 5:30 if you have questions about that. So let's continue what we were learning. So we're going on to matching leads to the heart regions. And last class, we talked about the different angles at which the limb leads read, right? We had lead one and lead two and lead three, which made Ian Silver's triangle. And then we also had AVR, AVL, and AVF. So the stickers that we place on the patients are going to pick up the ones in the front anyway, pick up exactly where we place them. But those ones on the limbs, as we know, talk to each other. So when they coincide with different regions or parts of the heart. Okay, so that's what we're talking about today. So let's go on with that. So right away, we have leads 1, 2, and 3. We're going to talk about those first. If you recall, lead 1 on your EKG goes from the right arm over to the left arm, correct? Right arm to left arm. That's lead 1. So on the heart, it looks kind of like this, right across the top. Anything that goes across the top is considered lateral, ending at the left arm. L in AVL stands for left arm and also lateral. So that makes sense. That's going to help you remember that. Cross this way is lateral, okay? And then lead 2, I'm going to have to move my face. Lead 2 is goes down from our right arm down to our left leg. Remember that one? So this is going towards the bottom of the heart. This is considered the inferior region, not the point necessarily, but the bottom part, the inferior region of the heart. So anything that goes to the foot, it bypasses the apex, and we're talking about inferior region, the bottom of the heart, okay? And lead 3, as we know, also goes from the left arm and ends at the left foot. So both lead 2 and 3 stop at the left foot, which means they both represent an inferior region of the heart. So why is this important to know? Let's put these in our little notes here. So lead 1 is lateral, lead 2 and 3 are inferior. So when I'm looking at my EKG, and I'm just going to look at my EKG in my packet here, I look at number 1 in the packet, and I can tell that 1 and AVL go together. We haven't learned AVL yet. But 1 is lateral, okay? But we know that 2 and 3 are inferior. So I can see that they are grouped together. 2 and 3, 2 and 3 right here go together. So when I'm looking at changes in the EKG, so if I see something that looks bad on the EKG in those leads, lead 2 or lead 3, then I know that there's might be something wrong in that area of the heart. So primarily we're looking for blockages because this is representing the blood vessels that surround the heart, and any blockage in the vessels that surround the heart end up causing heart attacks, cardiac myocardial infarctions, right? So if we have blockages in those, we're in rough shape. So the EKGs can pick up when there's blockages because the electrical signal looks a little bit different, okay? So make sure you write this in your chart. So lead 1, 2, and 3, that's Einthoven's triangle right there. And we'll move on to the augmented leads. Remember, these are the ones that talk to each other first and then go someplace else. So lead AVR, let's start with AVL. So AVL, as we know, goes to the left arm. And since it goes to the left arm, we only have 2 other leads to work with. We have the right arm and the left leg. They meet in the middle and go to the left arm. Okay, so that's our AVL. And since it's landing on the left arm, just like our lead 1 did, it's going to be considered lateral. I'm going to hide my face again. There we go, move my face. So AVL is going to be considered lateral because these two talk to each other and then go to the left arm, which is also considered lateral. Okay, hopefully that you understand that. If you need to pause and go back and re-listen to me say it a couple times, that's what that means. All right, let's take a look at now AVF. Okay, so AVF, remember when it's augmented, we use all three leads. We leave the right leg out because that is ground. So AVF is going to be our two arm leads meeting in the middle and going to our left foot. F is foot. And if it's going down to the bottom, it's also considered inferior. So AVF is inferior. We actually have three that are inferior. 2, 3 in AVF are inferior, and 1 in AVL are lateral. So those can be grouped together on our EKG. I will probably be drawing that on there, and you can use your EKG as well. I know we drew a lot on EKG 1 for our heart axis. So I'm just going to maybe put this on EKG 2 just so I don't have a bunch of stuff messing it all up. But my 1 and AVL go together. Okay. We know that 1 and AVL go together. And now we've just learned that 2, 3 and AVF go together as well. So circle them, just like that. So 1 and AVL go together and 2, 3 and AVF together. Now they go together when we're grouping them together for different regions of the heart. And the reason they're grouped together is because they all end at the same spot when we're talking about lead direction that we learned last class. Okay, so lead direction determines what goes together. And 1 and AVL are lateral because they both go end over here at the left arm, lateral or left arm. And then 2, 3, and AVF are all land at the left foot, so they're inferior. And then we have AVR. So what about AVR? AVR goes to the right arm. It's actually away from the heart. That is why our AVR lead has the QRS upside down. So it's negative, right? I talked about that too. Your AVR lead QRS is negative. Okay. And that's the reason because we're actually reading the heart away from. So we're, sorry, this is to the right. Reading it away from the heart, so it's upside down. We don't usually typically use this because there's nothing over here on the right side of our heart. Not over here anyway. Most of it's here towards the left, correct? So we leave AVR out of this one, okay? All right, so let's go back to, let's start talking about the V1 through 6. They are placed literally right on the chest, and you guys are doing that for homework this week. That should be fun. I can't wait to see your pictures. So V1 is placed right there on the anterior region. Makes sense. Front of our heart, right? It's right there on the chest, right there at the front of our heart, anterior region. V1 and V2 are placed right there. One is on the right side of the sternum, and one is on the left side of the sternum, fourth intercostal space. Okay. Now, this region of the heart is considered anterior, of course, because it's the front, but it's also to the right of the septum. Okay, so your septum does not run down your sternum. Your septum actually runs kind of sideways like this, right between V2 and V3 technically. Okay, and if it's a little bit off, it's a little bit off, but it's somewhere in this range. So V1 and V2 are going to be towards the right side of the septum. Now, when we look at V4, V3, I'm sorry, and V4, right? They are also anterior. You can see they're right on the front of the heart, correct? And they're also anterior, but they are to the left of the septum. Okay, so we would write this down as anterior left septum. Septum, if you remember, is that muscle wall that separates the right side from the left side of the heart. It's very thick, but we have some that pick up electrical conduction on the right side, and we have some that pick it up on the left side. So that's where we get the anterior right septal and anterior left septal. Then we have our two at the bottom here, V5 and V6, as we know. Those are considered apical because they're literally in our armpit, right? Way down here in the armpit, we're putting in our armpit. So V5 and V6 are down here. They're picking up the apex, not the inferior region, the apex, literally down in the armpit. We also call that low lateral. So occasionally you might see it written as low lateral. That is just the apex. Okay, so make sure you write these down, and they should make sense because where we place the stickers is exactly where they're picking up the electrical conduction. These should make sense to you, okay? If I go too fast, slow down. You can stop me and repeat if you need to. Like, just keep moving. All right, so let's group them together, and I kind of did that already for you with the 1 and AVL. So 1 and AVL go together. They are the lateral region of the heart. 2, 3, and AVF are the inferior region. And I actually did that for you on my EKG. I showed you kind of how I would group them, just so you kind of have a cheat sheet of what it looks like. So AVL, 1 and AVL go together. So when I'm looking for changes on the EKG, which we'll do in our next unit, when I'm looking for changes and I see a change in lead 1, okay? I see a change in lead 1. I'm also going to then look to AVL to see if I have the same change happening. If they have the same change, they match, and I have 2 changes, then I know there's something wrong. Now, if I only have a change in lead 1 and I don't have a change in AVL, then it's considered non-diagnostic. You have to have a match for it to be diagnostic. Same with down here. So we have 2, 3 in AVF, correct? 2, 3 in AVF. And I must have a change in at least 2 of them, 2 of the 3 to be considered diagnostic. If I only have 1 change in one of these, it's non-diagnostic. It means it's that person's normal. Okay, we'll get to that more later. All right, so V1 and V2 go together, and V3 and V4 go together. However, they're all anterior, so we can group them together. Okay, so if I have a change in 1 and 4, if I end up with a change in 1 and 4, but nothing in 2 and 3, that still counts as a change in the anterior region. And again, we haven't talked specifically about changes, but we'll get to that. So if I'm going to group 1 through 4 together. My last group that I'm going to group together is the V5 and V6, which, as we know, is the apical region. So these are showing up in our apex. So those are grouped together. So your picture should look something like this. I like pretty colors. You don't have to use colors. Use one like EKG2 because we kind of wrote up EKG1 a lot. But here is 1 and AVL go together, and 2, 3 and AVF, and then V1 through 4 go together, and V5 and 6. Okay, so that's just to kind of help you realize which ones go together. If you can visualize that when you're trying to diagnose and interpret EKGs, that's going to help you in the long run. Okay. All right. So as you know, I always have cheats. That's who I am. I call them cheats. It's just kind of more hints as to like what is makes it easier to remember stuff. Not necessarily cheats. So hints. So 1 in AVL, the lateral region, is L in AVL equals lateral, and they're both going to the left arm. So that AVL, that L in AVL stands for left arm and lateral. And then 2, 3 in AVF are the inferior region because F in AVF means foot, which is inferior down below. We know it's the left foot. We don't use the right foot because that's ground. V1 and V2 are the anterior right septal. V1 and 2 are located on the right front. V3 and V4 are located on the left front, so they're left septal. And then apical low lateral is literally in the apex, so that makes sense. It's called apical because of where it's located in the apex or near the armpit. Okay. All right, if I went too fast, go back and watch again. But that should be pretty easy. You saw the picture and understand that. If you need to do it again, just rewind and go back through it again. And again, you can always come see me on Monday if you need help. All right, last part of this is going to be quick. Types of artifact and how to correct them. So artifact is it's a word that's kind of similar to artificial. It means like they're not coming from the heart. So it can be caused by lots of different things, but you need to know when to recognize it so that you're not getting a false reading. So some of them can read kind of like arrhythmias do. We looked at AFib in last class, how there's a lot of wigglies and stuff in there. And if you're not careful with your lead placement and the patient moving and all that stuff, then it can look like AFib. We don't want it to misdiagnose somebody. So we want to make sure that we have a nice clean EKG, like the ones I have printed for you. They're nice and clean, it's straight, no wiggles and all that stuff. Okay, so artifact comes from the word artificial, just meaning it's not coming from the heart. So if it's not coming from the heart, where is it coming from? The first type is called muscular artifact. Okay, so it stems from tremors or noise from somebody just basically moving. So it shows kind of like below. So down here, you see this is the artifact. It's muscular artifact. It looks a lot like the AFib dib, and you can't see the PQRST very clearly, right? So if I give this EKG to a doctor, they're like, I can't even read it. You need to repeat it. So this little blurb right here, they're not moving the whole time, but this was probably like they sneezed or coughed or scratched their head. And you'll see that when you have someone hooked up to an EKG. We'll do it later in the semester. That when they move just the slightly a bit, we'll have some artifact like this called muscular. Also called tremors, can be called noise. It's muscular because it's from someone moving their muscles. Okay, even if they flex their feet, um, tense their muscles up, anytime they contract their muscles, we need them to relax and lay still. That's the best way to fix this one. Just have them try to relax and lay still. Okay. Next one's called AC interference. AC, as you know, is called, it means alternating current. Basically, it's the electricity we get from the wall. It's also called 60 hertz. And what happens is we see these little like caterpillar things. This is vibrations or electricity or electrical impulses coming from someplace not like the heart. Okay. So these are little caterpillar fuzzy things basically. So I see this a lot when they have another device on them, like a cell phone or their iPad, or they have a blood pressure cuff and it's going off at the same time I'm hooked them up. So a lot of patients in the ICU are hooked up to breathing machines and blood pressure cuffs and stuff that go off and vibrate and all that stuff. If it's going off and vibrating at the time that you're taking the EKG, you might get one that looks like this. And again, cell phones can do that occasionally if someone keeps texting or calling or whatever while you're doing it and it's close to your little box that has all the wires coming out of it, and it can cause this. The other thing that can cause it is just having too many wires all crossed, so they're too tangled. We'll get some artifact like this, just too tangled. So the best way is to make sure all devices or any device that they have is not close to where you're doing the EKG, not in their lap, not in their chest. I had this one patient, a Parkinson's patient, that had a device under her skin that actually helped with her tremors. And it set off vibrations. And I thought it was a pacemaker because it looked very similar to a pacemaker. So I put a sticker there. I realized very quickly, no, that was not a pacemaker. I was like, is that a pacemaker? And she said, no, it's a device for my Parkinson's. I'm like, oh. I moved it off and put it on her shoulder actually, and it was fine because it wasn't touching that device that was making vibrations underneath there. So just kind of troubleshoot it as you can. Okay. Last cut type of artifact is called wandering baseline. And it's exactly that. You can see this kind of goes up and down and up and down. This is the one I was talking about in class that mimics breath patterns. So when they breathe in, it goes up, and when they breathe out, it comes down. So this just stands for they typically um, either you didn't wait a few minutes to let the EKG kind of settle itself in and get, a few minutes, might take 30 seconds. When you first put the stickers on, it kind of looks all wonky on the EKG. And once the patient relaxes, in about 30 seconds in, you should be good. But if you don't wait, you might get some of this going on. But it also is if you put it too close to the diaphragm. So I talked about modifying and everything else. I know my echo techs need to put them a little bit lower because they need to put the probe there. Just avoid the diaphragm, which is right underneath the ribs. So avoid the diaphragm at all costs. It will cause your EKG to look like this. And then it's not straight again. And the doctor's like, hey, this isn't straight. Can you fix this? Okay. Doctors like it nice and straight. They're taking, you think about it, they're taking calipers, they're trying to measure certain, intervals and everything. And if it's not straight and it's not, nice and clean, it's very difficult to take those measurements. Okay. So how do you correct all these? Always check, obviously, that the wires are put on there, the stickers are laying flat. Sometimes when you attach the wires, the stickers kind of twist. Make sure the stickers are laying flat. Make sure you have all extra wires and cell phones out of the way, right? So you don't have any interference. And then the hardest part sometimes is making sure the patient's lying still, because if you're not lying still, we're going to get tons of muscle artifact. And I talked about the baby in class, and the babies are hard because they don't know what hold still means. And you just took all their clothes off, and they don't like it. And sometimes you have patients like that have Parkinson's; they literally can't hold still. My suggestion for that is if they have Parkinson's, their limbs are going to be the ones that shake the most. So try to move it in, modify it in towards the chest as much as you can, where the tremors aren't happening. So tremors typically don't happen right here in the chest area. Just move it all in there. Again, avoid contact with the diaphragm. And then if all else uh, fails, make sure you're taking you can move the stickers off the limbs and modify them, like I said. Sometimes the sticker is faulty, sometimes the clip on the EKG machine is faulty. So I usually, if I can't find a good spot, I'll put it one place. If it doesn't work there, I'll put it a second place. And by the second place, if it's still not working, I just replace the sticker. If that doesn't work, I check the clip. The clip might be broken. Okay, so it's just a process of elimination. Just walk yourself through it. Don't panic if you see artifact. You just got to double check everything as you go through. Take your time. Okay, pretty simple. All right, let's practice a couple. So here, can you find the artifact here? What type of artifact is this? What leads are effective and how would you correct it? So pretty obvious, it's in lead 2 with 3 and AVF, right? Now, what stickers do those coincide with? 2, 3, and AVF. It's the limb leads, right? So we're looking at the limb leads. Something is causing this artifact. And if you said AC artifact or 60 hertz artifact, you are correct. This is the wires crossed over or some sort of device in the way. So you would correct it by moving it away from the device, moving the device away from it. If the device is implanted, you'll have to move the sticker away. And if the device is just close by, you'll have to move the device. Sometimes you have to untangle the wires. That's really all that is, okay? All right, this one. Can you find this artifact? Which leads are affected and how do you correct this one? Take a minute and look at it. We want our EKGs to be nice and flat and straight, right? So you see some that aren't flat and straight, like this one right here. It's wonky. And this one down here also. This mimics, remember, it mimics the breath patterns. And you can tell which stickers are affected because you can look at the leads. This is V4 and V6. They are located down here, right? V4 is mid-clavicular, it's intercostal, and V6 is in the armpit. So those two are probably too close to the diaphragm because this is wandering baseline. Okay, a little bit over here too. It might correct it once you move V4 to V6, but definitely too close to the diaphragm, or maybe they just tried to do it too quick. Okay, simple. All right, how about this one? Can you find the artifact? You have this in your packet as well. So you can circle it in your packet if that makes it easier to notify, what it is. I can see artifact here in 2-3 and AVF for sure. Maybe a little bit in AVR. This is muscular artifact. Okay, this is someone moving, coughing. They have tremors. Maybe they're wiggling too much. Maybe their hands shake. But this is tremors. Okay, and maybe they're just tense. They're tensed up their muscles, and because they're scared and worried, that happens too. Okay, so the leads that are affected are 2-3 and AVF. You correct this by either moving the leads off a tense place, having them relax. You may have to move it off the limbs and make it modified if they have tremors. Okay, so it might be just a moving of some stickers. Should be pretty simple. And the last one here, this is an interesting one. It would be considered, I know you can see the kind of like all over the place, right? This is nice and flat, and then we have all these crazy things everywhere. So it's one of those that's considered muscular artifact. It's not wandering baseline. It's considered that because the stickers probably are not laying flat. Okay, that means the stickers are kind of like up on their end, on their side, and it's just not making a good connection. So it's picking it up here, and then it's here, and then it rolls and does that. It's got this side and that side. So we've got a kind of all over the place. These are almost always sticker related. So just go back and make sure your stickers are nice and flat. You have it clipped on there properly, and everything's laying nice and flat, and the patient's laying nice and still. So this is a form of muscular artifact. All right. I think we just wrapped that up. That's awesome. So if you have any questions, and here I am, make myself big again. All right, so if you have any questions, I will be available, obviously, on Zoom on Monday, on the 30th, between 4:30 and 5:30. So try to get, obviously, this stuff done before that. You have the EKG sticker homework, and then you have the unit exam to do for this week. I won't see you for 2 weeks. I will see you again on, I believe, the 6th of February. Is it the 6th? Yes, Monday the 6th. All right, until then, I'll see you soon. Let me know if you have questions.